somebody who's had, holes poked in their chest or in their heart. It can blow things out. It really does. I mean, it's just physics. So.
Dr. Oka,
Yes.
just for clarification for the pad placement, where do you recommend them to put it?
So as long as the ventricle is in sight, between the two, because ideally you want to do something like this,
Right.
but obviously that's going to be in the way. So what we do in the OR, we try to put something maybe down here and maybe something up here. Basically, the electricity has to cross the ventricle.
Okay.
Okay, and that's fine. It doesn't have to be perfect because once we get the chest open, we can do internal defibrillation. So it's really just for the very, very short period of time that, if we need to defibrillate earlier than that.
Okay.
There are some questions about, okay, if it's a mini sternotomy, what do we do, blah, blah, blah. Again, mini sternotomy means the sternum is not entirely split. It's only split for the maybe upper third. So you have an intact sternum on this bottom half. It only gives you access to a limited portion of the heart. So it's not ideal in a patient that's coding. But if it's tamponade, there's a possibility by just opening this we'll be able to relieve that. But if it's not, then we'll probably need to complete the sternotomy. Okay, and that's why we need the saw. Because if you're going to try to do open cardiac massage or trying to get to an area that's bleeding, you can't get to it through a small incision like that. But you probably could relieve tamponade through a small incision. So it doesn't automatically mean we're going to convert, a mini to a standard sternotomy, but the likelihood is certainly there.
What is your argument about, compression, that when we do the ACLS recommendation versus?
So people, everybody has a little bit of a different take. The general teaching was, don't do chest and compressions on patients that have had CABG because you could tear a graft off, right? So it's true, but it's pretty difficult to do that. And again, in a dire situation, we're not worried about that.
Okay.
So I would say, again, if we're not here, then don't worry, just do what you need to do. Yeah.
Let's say that we have Bauman or Rosamond or Aboyan or somebody else here in the hospital. What would you expect their role to be?
Again, they're still not trained.
Correct, I understand.
CT surgeons. If I would generally, if they could help run the medical code, I would be more comfortable. I would assume, let's say for whatever reason we're tied up somewhere and we can't get here in an hour or something like that, and they'll probably call us, and we'll probably say, "Can you open the chest or not?" I mean, that should be kind of just a physician to physician thing. I'll tell you. So what happened once was this was actually when I was a fellow. And I hate giving these anecdotes, but it's a good one. A patient that I had operated on coded in the middle of the night. And I only lived 5 minutes away, but it still takes in the middle of the night 15, 20 minutes to get back to the hospital. So, of course, they call code. There are residents in-house. So the chief surgical resident, who also wanted to be a cardiac fellow, who was a really good guy and a really capable guy, responded, and he opened the chest. But the problem was, it was a CABG patient, and when he put the sternal retractor in, he had snagged the lima. So when he cranked the thing open, the lima tore off of the heart.
Oh my God.
So, that's an unmanageable situation. Meaning, if something like that happens, that's game over. There's nothing you can do up here.
Yeah, no, you have to be in that room.
So it's going back into a chest is always a little dicey unless you know what you've done and what is where. And so it's a lot to ask of a surgeon that doesn't do it all the time. It would even probably be, a lot to ask of one of my partners. If they actually hadn't been in the surgery and they don't know what to expect going in, they're probably going to be like, what is where, right? So in general, as I said, even if it's another physician, I would recommend they not open the chest. So that's the short answer, I guess.
Would you ever have them just go ahead and open and maybe cut one or two of the wires to see if it would relieve anything, or?
Up to there, it's pretty safe. Beyond that, I'd say no.
Okay.
Yeah.
Okay. I'm just asking you all these questions.
Yeah,
just
because,
to-
I
It's a
mean,
good
there's,
question.
you know, there's clot in there,
Yeah.
and, you know, there's little things that we have to kind of look for. I mean, even after a couple hours, things can get pretty stuck in there just from the clot. And if you don't know what you're doing, it's very easy, especially if it's a cabbage, to tear off a graft. Because the grafts are just kind of in there like, you know, little spaghetti
Mhm.
strands, so.
What I was telling them before, and it hasn't happened with any of your patients, but it has happened where the mediastinal chest tube has been pulled out.
Yes.
So in the past, we have taken every patient down. Is there any situation where you would not take that patient down?
It depends. I have been burned by this. I have been burned by patients that either clot their tubes or the tubes fell out early. Sometimes you get away with it, sometimes you don't. And there was a patient that I thought I'd get away with, but in the middle of the night he tamponaded and we had to really take him back. So I think it's case by case. If the patient had been really, really dry up to that point, it's probably okay. But if it's an oozy patient, you know, maybe we end up going back.
Well, it's the patient that's always, that everybody is milking and doing
Yeah,
little mini stripping
yeah.
and all that kind of stuff. It's never the patient that is like 20, 30 cc's out an
Yeah,
hour,
so
that
it's
type
the
of thing.
patient that's important, so
Okay.
I would suggest that, you know, everybody kind of just go through the card
Right.
and gets familiar with what's in there, know where it is, and then, you know, I would suggest that, you know, if you have an empty room,
Yes.
Mhm.
kind of see what
Practice.
you need to do. When I mean moving the table out, getting the headboard, you know, imagine you have all these pumps, right?
Mhm.
There needs to be enough room on either side of the bed and probably at the foot of the bed to have people standing and an instrument tray open, so.
Correct.
Okay.
Okay.
Anything else?
Anything else that you want to see added to the cart here? I know you've gone through the cart, you've looked at stuff.
No,
Anything else?
I think I was pretty happy with it, just because if there's too many things, then everybody doesn't know what everything is.
Right.
So.
And then for your history, because you were part of some of the initial conversations we had about what type of a tray that we would keep, and I'm glad that you're here, both of you are here. We are now using a general pack tray
Okay.
to open because it was felt, it had a lot of stuff in it. It already had one set of sterile suction. We
Okay.
have additional that we set up, and we had enough of the drapes. Now, it's been a good almost 2 years since we've had that discussion with Dr. Vial. I don't know if there's a better pack that we should have.
Is it the soft pack?
It's this one right here.
So,
I think a general is good because you're going to have a,
This is the one. So again,
Yeah.
it has a lot of this stuff in it already, you know, et cetera, so that we can open that. We also have individual stuff. I mean,
it has a lap drape.
yeah, it has a lot of the stuff. So that was.
This is good.
You know, I mean, there's a ton of stuff downstairs, all the different packs, and then the other thing is that we have now the ability to look at any setter pack that we have. So I don't know, or if you want something that's done at CPMC. Those are the questions I had for you.
Doesn't really, I'm not sure what's in it, but it seems like.
Again, it's a general pack. It's good for the general draping, the gauze pads, et cetera, et cetera. As I say, it's got sterile suction already set up. The person is just handing that off to
Sure.
a non-sterile person to hook up.
Yeah, no, it sounds like it'd be fine.
Okay, because this is the last tray that, and actually who helped with this is also Cindy Stoney, if I'm saying her name correct, down in the OR, about what you thought would be the best thing.
It sounds like pretty much everything. we
Okay,
need is in there.
I do have one question for you. As you know that we've gone, we have this tamponade tackle box with all kinds of stuff in it. This is also one of the things that was requested to be on the
Oh, okay.
open chest. Is my question to you, and it's absolutely fine that it's kept, that's not an issue. Is this something that is still needed, or with all the different catheters that we have here?
So I think we're kind of, you might be jumbling some medical, a medical tamponade patient.
This
and
is a
sort of-
request from your
Yeah.
team to have this.
So this, I'm not sure I would ever use this other than like a pneumothorax or a hemothorax. I mean, it makes no sense to use this in a surgical patient, I guess. Unless again, the tube is clogged or you've lost the tube and you have an accumulating pericardial effusion and you're trying to get, but we wouldn't even do that blindly. We do that under echo guidance or something.
Mhm.
So I don't think this is something that we would use. This is something that I would use for like a hemothorax or a pleural effusion or a pneumothorax essentially, but not for,
Okay, that's
big
on,
time
that's on our
bleeding.
cart, which was the request. Is it, if
Okay.
it's not needed, we can be moving it to another location where some of the tamponade
I
stuff
personally
is.
can't see myself using it,
Uh-huh.
but I don't know about.
Would that be a question then for the other two
Yeah, if
main?
they would ever use this. I mean, I just don't
Okay.
understand what the utility would be. So
Okay.
what I would really suggest is go to a room, put this dummy on that room, and pretend that it's a patient, and then kind of say, okay, what do we need to do to prepare this room in order to get this patient prepped and draped? Because that's really what needs to happen. And you would be amazed at how many things we have to get, like, move out of the way in a room. There's a lot of stuff.
And time it, doesn't.
And time it, exactly. And again, there's lines, right? There's tubes and all sorts of things, need to kind of just generally be cleared of this area, right? Whether it's endotracheal tube or everything needs to just generally be put on the side. So it just takes a little bit of pre-thought. It's not difficult, but doing it on the spot versus having put 2 or 3 minutes of thinking prior to that event is different. So once you know what the goal is, it's not difficult to figure out how to get there. So.
And the goal for today is to literally go through the cart and then go through individual stuff so everybody can play with, like you say, like the internal different pads.
Sure.
Looking at the saw.
Yeah.
What comes first? Like I was telling them, I think the worst case I've ever had in here was the day that PTCI went bad and we had to open the chest.
Mm-hmm.
We didn't have the luxury of having a sternotomy already. So you set things up differently. I mean, everything got prepped. I got the saw assembled first, et cetera, because that was going to be needed before we could get into the chest. So, little things like that, and then going over the sterile to fit pads, how you hook those up. They're different than what we normally have. So we're going to go over all that hands-on stuff, and then hopefully once people know that, then we can drill.
Yeah, it's just about getting comfortable. That's
Mhm.
what's in here.
It's like anything else we do.
And this is just a little off topic, but it's really important. So we do have some brand new partners this year,
Mhm.
and we have some like MJ who have proven that they're ready. So she's currently hopefully getting her second heart this week or early next week. So for a Christmas gift for everyone, along with a little something else, the Charges and I are actually making some little laminated info sheets for our new heart nurses that are existing that basically say, if you have Dr. Oga's patient, this is what is most important to him, and if you have Dr. Vial's patient, this is what is most important to him
Sure.
when you call and what he wants. You guys are quite different. Dr. Vial will tell you his big thing is, I want to have 2 liters in and 3 liters out regardless.
Yeah.
They've heard me preach this stuff. And acid-based balance, always make sure you're getting frequent ABGs and watching it. And people are like, but Dr. Oka is a little different. So now that
Yeah.
we have a lot of our new people
Yes.
here, can you just talk about what's most important to you
So-
and what people should say primarily when they call you?
So again, as I said, the best question is the best phone call that we get is you have a problem, okay? You present the problem, but better yet, you actually have some sort of solution for that problem, and you want to make sure that that's the right thing to do. So, because then we actually see behind that process, you've actually thought about it, and you're presenting us with a solution, which most of the time is going to be right. May not be, depending on a certain patient, but most of the time it's going to be right. What we don't like is we get a general phone call with a lot of information about the patient, and it's unclear as to why we're getting the phone call. So we get to go, oh, the blood pressure is this, and the hemoglobin is this, and platelet count is this, and K is this, and the bicarb is this, and the is this, and blah, blah, blah. So what is the question? Okay, it's better it says, listen, this is my problem. The blood pressure is 70. I'm on this much strips, and these are my numbers. I would like to do this. Do you concur? I mean, that's kind of the best phone call we can get.
Okay.
And if you've thought through it right, you'll probably get to the right answer, which we will agree with. And it allows us going forward to establish more trust in your judgment, right? Which is basically what we want, is to individually know, okay, if this person is saying I'm in trouble, I know this person is that the patient is in trouble. With regards to like individual surgeons, unfortunately, yes, everybody has preferences, and there's no right or wrong. It is, some of it is empiric, some of it is based on science and physiology. For the eyes and nose, I particularly don't care the first couple of days, because generally speaking, a patient that comes up from downstairs is fluid overloaded by definition. By going on a cardiac performing bypass, they're liters and liters overloaded. And so even though the patient may not be eating or drinking, the body still has a reservoir of 2, 3, 4 liters of fluid, which, if the patient gets better, will start to mobilize. So they kind of have an internal IV for themselves, and that's what I kind of rely on. So, and then the second thing is, it's hard to target an output goal, because a lot of patients, as you've probably seen, they go into kind of a renal dysfunction. You know, their creatinine starts creeping up, and they're not making a lot of urine. And there's no sense in flogging the kidneys then. You just have to give them enough time to recover, and then they're going to do what they're going to do, which is make a lot of urine. Sorry.
That's okay.
Liv? Yep. Mm-hmm.
I just have
Okay.
to ask it. I don't
Yeah,
know off topic.
No?
Yeah,
No?
it should be left atrial thrombectomy and left
Right
atrial
here.
appendage.
We're very fortunate that he's
Yeah,
here with us.
yeah. Thanks. So, you know, I don't particularly mind like a liter in, 2 hours out. I mean, I don't want to see 10 liters in. You know, that's just way too much. You know, if you're having to give that much fluid and your blood pressure is still low, there's a different answer. That's not the right answer, right? So I don't want to see that, but, you know, if somebody took in 500 and they've peed out 1,300, it's probably okay if their hemodynamically otherwise okay, all right.
Okay.
Now, several weeks, now, down the line, like, let's say a week from the surgery, if they're only eating 200 a day, that's a problem. Because, yes, they're gonna get dehydrated. But early on, in the first 24, 36, 48 hours, if they're not consuming a lot, which is normal, I mean, they don't need it. Their bodies have enough fluid in them. If they properly mobilize that fluid, I think they'll be fine. That's how I feel. Sorry. Blue? Yes.
Does that make sense, everyone?
Yeah. 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 I will do it. Yes, I will do them. Okay.
It does.
Thank you. Yeah. A quick thing with regards to pH. So I do know some of my partners will look at a bicarb, right? And they'll actually give bicarb. Again, I don't necessarily do that, because if a patient is acidotic, it's a reflection of the physiology. So usually, if you've noticed, most patients that come up from heart surgery are a little acidotic. It's because they've been on the pump. While they're on the pump, they're vasoconstricted, and some of their organs are producing acid that isn't really hitting the circulation. And as the circulation restores, then that gets washed out. So, you know, a bicarb of 18, 19, or a base deficit of like 3 or 6, you know, post-pump, especially if it's a longish run, it's pretty common. And so I don't necessarily treat that with bicarb if their pH is fine. Okay, if their pH is 6.9 or 7.1 with that a low bicarb, and despite that a low CO2, yes, I will treat it, because at some point when you're so acidotic, your pressors and your inotropes don't work. Okay, there's a range of, you know, physiological range where your body is primed to respond to things, and below that pH, things stop working. So, but if your pH is 7.33, but your bicarb's 19, I don't really care. I'm just going to give the body the time to do what it's going to do, which is, you know, again, your kidneys are a lot smarter than I am. You know, they're going to the kidneys are going to figure out what they need to do. So that's why I don't aggressively give bicarb. As long as the pH is fine, I don't really care. I do want to see a trend better, though. You know, if my bicarb's 19 and 3 hours later it's 15, and then it's 12, and, you know, my cardiac index is 1.4, well, that's a problem, right? So, but the problem is not